I'm having out. This is a group of lectures for women about hormones and how they kind of influence and relate to their lives and quality of life and well-being and health. So if you missed the first couple of lectures, I really highly recommend that you listen to those. It was an overview of hormones. There was a lecture specifically on routes of administration of hormones. So how do you want to take these things? What's the difference there? We did one on weight loss. Last month, because January is traditional weight loss month with New Year's resolutions. And tonight we're going to do a lecture on testosterone. And I call testosterone the forgotten hormone because oftentimes we're thinking about perimenopause and menopause as being related to estrogen and progesterone, but testosterone gets forgotten. And so I thought having one evening entirely devoted to testosterone was definitely worth it. Okay, so as we start talking about perimenopause and menopause, what are these things? What's really going on? Most of you know that we have all of these eggs in our ovaries. At birth, we're actually ovulating monthly, using up those eggs, and eventually we get to the point where our bodies are not designed to reproduce anymore, and so the ovaries stop working in terms of making eggs, and since that whole process stops, the production of the hormones and the cycling of the hormones that's associated with ovulation and our ovaries actually ceases also. So when that happens, the important thing to remember is that we're actually losing all three of the hormones that come from our ovaries. So that's going to be estrogen, progesterone, and testosterone. But testosterone is often forgotten, and I think that part of that is because we think about testosterone as a male hormone. That's kind of the first thing that comes to mind. We think about estrogen and progesterone as female hormones. But indeed, again, all of these hormones are made in our ovaries and they're all incredibly important in our body. I think the other thing that's interesting, and this is really kind of, again, our bias in terms of hormone replacement therapy, is when women develop menopausal symptoms, typically they're going to their traditional physician, a primary care physician or an OBGYN, and we are trained as physicians. I'm a medical doctor. I'm an internist by training. I have an integrated health practice, so my philosophy is a little bit different now. But when I was first practicing and trained traditionally, we're always thinking about diseases. So we really almost categorize menopause as a disease that should be treated, and indeed for many years we treated menopause with drugs. We didn't do hormone replacement therapy, we were actually doing hormone substitution therapy. And so tonight what I really want to do is I want to stop thinking about menopause as a disease process, and I really want you to understand that it's a hormonal imbalance, and anytime we have imbalance in hormones, we're not going to feel good. So the goal really has to be to rebalance our hormones in terms of conceptually thinking about feeling good, having disease prevention and quality of life. So we are trying to re-establish balance in the body. And one of the principles that I always use in my practice, is what I always talk to patients about, is what we're really trying to do is reproduce nature. We're trying to recalibrate, reset, redefine what our body was originally defined and supposed to be doing. And when we do that, we always win. When we get the function of the body back, we always win. And the good news is that when we do that, we're not going to have side effects and issues and problems, either related to the actual disease process or oftentimes the medications that we're given for the disease process, which have a whole list of side effects too. So every single lecture on hormones, every patient interaction that I have with hormones, I always want to emphasize three critical things that you really must follow for safe and effective hormone replacement therapy. And every single lecture I discuss these things, but they're worth repeating again tonight. So the first rule that we really always need to follow to reproduce nature is to use the correct form of hormones, right? We want to reproduce nature and put back into the body what was originally there. And that's what we're typically thinking about when we talk about bioidentical hormones. They're identical to what was in the body. They can come from a plant source, which we'll hear you talk about in the other lectures. These are actually chemically converted in a pharmacy, in a laboratory, in a very controlled way into the identical hormone that's in your body. So for instance, if I take a molecule of testosterone out of my body right now, and I say, hey, I need to replace that, whatever I put back in should be identical and indistinguishable in my body, one versus the other. The next thing is the right amount. And so, when I started doing hormones in 2000, and I've done hormone replacement therapy now for 17 years, it's always been bioidentical. It's predominantly focused on women. I see thousands of women in my practice. And now that bioidentical hormone replacement therapy has become a little bit more vogue or popular, I see a lot of women on the right form of hormone, the bioidenticals, but their levels have never been measured or they haven't been remeasured on the hormone replacement therapy to see if those levels are actually correct, which is critical. It's just like anything else in the body. If you have too much, it's going to be a problem, and if you have too little, it's going to be a problem. And the last thing is balance. And one of the most interesting things that I learned when I was researching testosterone and new science and hormone replacement therapy with testosterone is how even that hormone balances out some of the other effects of the other reproductive hormones, specifically estrogen and progesterone. They're meant to go together, they communicate, and they actually create health, disease risk, and if done correctly, again, you're not going to get side effects, issues, or problems. So the right amount of each hormone is going to be about measuring levels before and after menstruation, and that balance is going to be obtained by actually having those levels also. And again, the other lectures are really great at talking about that. Okay, so we talked a little bit about this, but what are the most common menopausal symptoms? Hot flashes, night sweats, vaginal dryness, perhaps changes in bone density. And so again, these are all things that are related to estrogen. And so we're really thinking about estrogen predominantly. Probably when we think about menopause, it's what was traditionally replaced. It was the only thing that was replaced. Unfortunately, the issues were that it was in a synthetic form. So Premarin was the actual estrogen that was driving corticosteroid that a lot of women learned to dislike and had issues with. And the other hormone that we typically think about with menopause is progesterone, and that was introduced because if you give estrogen by itself, it will create endometrial cancer, which of course is something that none of us want as women. And so it became very important that progesterone was given with estrogen to prevent that process from happening. So these are really the two hormones that are thought about in terms of menopause, but what's really interesting is that if you only give those hormones to a woman, you're actually decreasing her testosterone levels as a result of focusing only on those two. So now if you begin to think, okay, so most women are going to have low estrogen, progesterone, testosterone. They're going to get either their estrogen or their estrogen and progesterone replaced, and that's going to worsen their testosterone. Then we really begin to think about, well, what does testosterone do in the body and why is it important and how are we going to actually resolve this? It's interesting too because that synthetic form of progesterone called hydroxyprogesterone that was given to women for prevention of endometrial cancer also specifically inhibited sexual response by lowering testosterone. So all these things that we really thought about in terms of menopause actually made testosterone worse. So, one question that we always want to ask is, well, do women have testosterone? I mean, is it an important hormone? Well, women predominantly do have estrogen and progesterone, but testosterone is incredibly important. And men have testosterone predominantly, but indeed, they also have estrogen and progesterone in their bodies, and those things are important also. So whether or not I'm replacing a man or a woman, all these things being present and reproducing nature is this critical thing to do. So pre-menopause, where are we getting our testosterone? It's predominantly from our ovaries. And so obviously post-menopause, they stop making the hormone. A lot of women have what we call surgical menopause, where they're having a hysterectomy, the ovaries are removed, they instantly go into menopause. Post-menopausally, predominantly testosterone is made for our adrenals, and we've talked about adrenals in some of these lectures, but there are these two little glands that sit on top of our kidneys. They're actually responsible for balancing stress in our body. And because we live in the current world with lots of stress and, traffic and finances and, families with their good and bad sometimes, we've all just gotten through the holidays. We all have stress. And when we have stress, this actual hormone that turns into testosterone and cuts our stress in our adrenals actually declines with both stress and age, and so that secondary source we lose and our testosterone levels are low. The other important thing is something called sex hormone binding globulin. Come on in. Which is the transport protein in our bodies for our sex hormones. And what happens is that level can rise, and essentially these transport ships can bind up all the hormones in our body, including testosterone, and make it unavailable to our cells. So if we have high sex hormone binding globulin, which should be measured in a woman, and I got asked the question tonight, kind of where do I start with hormones to support the women's position, and unless you're actually measuring these levels and you know what's going on with each of these parameters, each of these barometers of kind of health and hormonal balance, you may miss something important, like having the right amount of hormones, but having it all bound to sex hormone binding globulin. So we're pretty objective in the lab. We want these numbers in my practice so that we can actually get it right. And that's really become an important part of our success picture. I mean, lots of women feeling great, women not having side effects and issues and problems because we're right on target with these things. Okay, so what does testosterone do in women? I thought, well, let's just kind of get this first one that we always think about, off the table, the increasing sexual enjoyment and desire. And certainly we don't want to, underestimate how important that is, because that's an important part of our relationship and enjoyment in life. But what I really want to focus on tonight, too, is how important testosterone is in terms of lots of other things in our body. So, obviously, lower abs and sex drive, okay, that's in that sexual world, but look at these things beneath this and really start thinking about, where am I in terms of these things? These are things I hear every single day from women who've gone through menopause or entering that period of hormonal imbalance. I have low energy. I just don't feel like myself anymore. My muscles seem to be going away. I go to the gym and I'm not able to heal and repair like I used to. I don't think I have the same metabolism. My bone density, I work out and, my bone density, I went to the doctor and he said I have osteopenia or osteoporosis, which is loss of bone density. I feel depressed, I feel sad, and indeed, I thought this was an important number because it's a significant number. 50 to 70% of women experience physical and emotional symptoms, imbalances during menopause. It's a large number of women, and I think, for me, these women just think they're sad. What they really are is they're really hormonally imbalanced, and they don't feel like themselves. And when they get back into hormonal balance, they can really begin to feel like themselves again. Women report incontinence, with sneezing or laughing or physical activity, and that whole kind of midlife, mid-weight weight gain. It's interesting. What women tell me too is, I used to gain it here, but now I gain it all in my midline. And again, that's specifically related to the hormonal changes that are happening in perimenopause and menopause. So levels. Significant numbers here too. So women in their 40s have half the level of testosterone that they do in their 20s. And if you begin to think about, again, what this stuff does in your body, that's an important number. There's a 26% decline in testosterone between 42 and 50. If you go through surgical menopause, or you have a hysterectomy and they take out your ovaries, literally within 24 hours your testosterone levels will drop by 50 to 70%. That's true for estrogen and progesterone too. Yeah, and so all of a sudden, you have your surgery and literally you can start with your hot flashes and your night sweats and all those things, in the hospital. And again, when we used to only give estrogen to women, usually the synthetic form, or when we gave it and we didn't give the other hormones, unless estrogen is given transdermally, which means through the skin, it can increase hormonal body globulin levels. It doesn't always do this, but it's important to know that. One of the lectures that I did earlier was about how to give hormones. There's not one way we do things in my practice. Sometimes we do things orally, sometimes we do things sublingually under the tongue, sometimes we do cream, sometimes we do red pads. But we're always doing it with objective evidence and information that tells us this is the right form for the right person to create that balance. So, some important numbers just on the sexual dysfunction portions of testosterone. 43% of women have sexual dysfunction, and most commonly they describe it as a lack of desire. When women are not sexually active with their partners, studies have shown that they're not feeling as satisfied and as connected. So it becomes an important piece for both men and women. Testosterone has a direct effect on the brain in terms of desire. Testosterone converts to estrogen, which also is important with the brain for desire. And I always tell people too that it's not just testosterone that creates sexual desire and sexual satisfaction function. It really is the combination of all the hormones. Testosterone levels in sexuality are, however, directly related in women also. And testosterone has a direct effect on the genital area and will influence orgasm. And so that's the other thing I hear about women who are sexually active postmenopausally. Sometimes they have difficulty reaching orgasm, and so that sexual activity becomes very frustrating for them, as well as their partners, because they just can't get there. So testosterone in the breast. So this is where I really want to begin to show you how many other roles testosterone plays in the female body, so that you can really kind of wrap your heads around, wow, this is not only important for the sexual aspects, but it's really important for my overall health. So testosterone actually has a protective effect on breast tissue in terms of breast cancer when you give a look at estrogen. And this is everything that you're hearing tonight is out of recent literature. One of my goals with these lectures is to get back into the literature and look at all the recent information, so there's references at the end. But that was new information to me. We're always thinking about, if I do hormone replacement therapy, will I have a risk of breast cancer? So interestingly, testosterone can actually provide protection. It does that by preventing this excess proliferative piece. So, we oftentimes think that cancer is this proliferation that's kind of out of control. So testosterone helps to protect that. However, since testosterone can kind of biochemically, these hormone conversions pathway into estrogen, it's not recommended for women with hormone-related cancers, like hormone-sensitive or hormone receptor-positive breast cancers. And whenever I see any of these women in my practice, we're always working with their oncologist to make good decisions about what they can and can't do. Testosterone in the heart. So sometimes I hear, and I've heard this predominantly with men, that testosterone increases heart disease risk. The science says it does not. What we actually see in terms of risk factors for cardiovascular disease is that it lowers cholesterol, LDL, and triglycerides, which are all highly correlated with heart disease risk. It can also lower HDL, which would be a negative thing. But again, we're following these things and watching these things. It doesn't do this all women, but obviously we want to keep HDL levels high because that's protective in cardiovascular disease. It actually improves vessel health. So the blood vessels get healthier as a result of testosterone being there, and blood vessel health is something long-term that we really want. And inside of blood vessels, when given with estrogen, testosterone can actually increase plaque, and plaque, as you know, is once again associated with cardiovascular disease and progress. Testosterone in your bones. So most of us think about estrogen and bones, but it's critical to bone health to have testosterone on board. It prevents and protects against both osteopenia and osteoporosis, which is that progression to kind of profound bone loss. It prevents the loss of height that we see with many women when given with estrogen. Testosterone in the uterus. So remember again, we gave estrogen to control menopausal symptoms, then we had to come in with progesterone because estrogen by itself was creating endometrial cancer risk. And so, the question is, well, what's the role of testosterone in the uterus? And it prevents against endometrial growth also. So it's protective in women who are doing hormone replacement therapy that still have their uterus ovaries. Testosterone and weight gain. So we've talked about this a little bit. Low testosterone leads to weight gain, and specifically it's going to be in the trunk, kind of the midline area. That is the area that increases a woman's risk for all the different degenerative diseases of aging. So it's not holding it in your hips and thighs that the risk comes from, but it's holding it in this midline area. So when we start talking about cancer, diabetes, heart disease, stroke risk, everything that we don't want to get as we age, it is related to kind of our abdominal girth, shall we say. So testosterone controls abdominal fat, both inside and out. So sometimes too, it's not only the fat on the outside that gets us, but it's actually that we're laying down body fat on the inside of our abdomen and these vital organs, and that is something that we don't want to do for long-term health. I mentioned that if our weight is in our hip and buttocks, that's not associated with long-term disease risk. Testosterone decreases cravings and hunger, and that's kind of interesting to me because I think, again, a lot of people kind of postmenopausally, they're like, I never craved sugar before, and now I want this stuff all the time. And it's very important to increase metabolism. And again, how many times do I hear women say, it just seems like my metabolism is slowed down, things are just not working, like they used to. It's so much harder for me to lose weight. Okay, testosterone in the brain. So, how many times too have we felt postmenopausally like our brain doesn't work? We can't multitask, we can't find those words, we're forgetting things. So testosterone is really important for the brain and brain function, both verbal ability and just general cognitive ability. We're known as women as multitaskers, and a lot of women just say, I just can't keep as many things going all at the same time, now that I've hit menopause. Testosterone and well-being. So this is really interesting to me because, again, some of the most commonly prescribed medications are antidepressants and medications that are about well-being. And I think a lot of that happens in the perimenopausal and the menopausal woman. And so when we go in and we're only replacing estrogen has very little effect on a woman's well-being. But indeed, the risk of depression increases significantly after menopause. And testosterone is the hormone that really addresses well-being and depression. So, it becomes very important to me for that reason, because this is really about quality of life. Tell women when they kind of hit perimenopause and menopause, you very well may be at the midpoint of your life. So the question becomes, what's the second half going to actually look like? So a little bit about methods of administration. So let's say that you're checking off the boxes, I have these things, you go see the physician, it's documented that your testosterone levels are low, maybe with the other hormones, you're getting a good combination of these things, you're balancing things, you're following all the rules for the benefits and the safety piece. How would you potentially take testosterone? Well, there used to be an oral synthetic form. I'm never a fan of synthetic forms of hormone because, again, they're not identical to the body, so the body doesn't recognize and utilize them like they would the natural form of the body. And the oral form didn't make it in our marketplace, so that is off the list. Pellets. Many of you may know people who have actually had a testosterone pellet plates. This was very popular in the 50s and 60s. It kind of went out of vogue, and now it's really come back into vogue both for men and women. I am not a personal fan of pellets because there's so few women that actually get it right with the pellet in terms of the dose and the length that that pellet actually lasts. So the thought process here with the pellet is that you have a little round pellet that has this slow, gradual release of hormone that you put underneath the skin, and it's supposed to last, I think originally they were talking about 6 months. Most of the women that I talked to say about 2 to 3 months. So if it indeed releases the correct amount of hormone, and you've had to put it in and so on and so forth, they can be really, really wonderful because it is taken care of for 2 months. You have this slow, steady release of the hormone, and everything is perfect. But if your levels get too high, and these are most of the women that I see, you're now stuck with that for 2 to 3 months. And again, there's nothing you can do. You can't take it out. You can't make the hormone go away. So you're running around with high testosterone levels, which create other hormonal imbalances. And any hormone out of balance is not going to make you feel good. Conversely, if it's still too low, then you're going to end up with one of these other forms of hormone replacement therapy. So you're going to have to kind of top off that low level with a patch or a cream or a spray or a sublingual. So my personal preference is to use these last 2 forms, which means transdermal through the skin, sublingual, which means under the tongue, because you can adjust it. If people are having any sort of issues, you can go right in, change that dose. You get this daily administration. You kind of pulse it like your ovaries would make it, and I think that works best for women. I get the best results there. What are these side effects? The first 2, peach fuzz and acne. Who gets that? And it's really going to be women who are typically kind of fuzzy to start with. They just naturally have a lot of hair. That can be an issue for them. And if they naturally have breakout, and some women are just more prone to breakout than others, once again, when they replace testosterone, that can be an issue. If you're not prone to either of those things, most women don't have any issues with those at all. Increasing hemoglobin, again, this is typically with super physiologic, too high levels. Again, with the pellets, you really want to, watch these things because sometimes it can be serious. We're monitoring blood levels all the way through. The risk is that if it would be too high and it would increase your hemoglobin level, it could put you at risk for clotting from that standpoint, but not at physiologic dosages like you're actually making in your body like we replace in practice. But it is important to listen to your patients, to have close contact, to do appropriate blood levels, to see them regularly, and to actually monitor these things. That's a part of the safety and responsibility of good hormone replacement therapy doctors. So where are we? Well, we still don't have these large 50,000 women randomized clinical trials that actually show exactly this group had this, and this group had that, and this group had something different, and this is how it all played out. So right now we still give testosterone in what we call an off-label way, which means that we have small clinical studies that show different effects of things, but we don't have these large comparison type trials. It's interesting in medicine too, we always like to give one thing and then study an effect. But the reality of hormone replacement therapy is it's really done best in combination. So what I'd like to see is a large group of women who are getting, right form, right levels, right balance of all the hormones, and compare them to women who maybe aren't getting anything or who are not being monitored and cared for in that way, because that's where I think we're going to really see these distinguishing pieces between what happens when you do it right and what happens when you don't do it right or you don't do it at all. So causes of low testosterone, it's interesting. It's the drops of age, the drops of menopause. Sometimes when women have other health issues and they really chemotherapy of any part of their body. They can go into sudden menopause and lose all of their hormones, as well as radiation therapy to the pelvis for whatever reason. A bilateral oophorectomy means that you have surgically both of your ovaries removed. Again, if you have excessive sex hormone binding globulin levels, that's going to transport protein for your sex hormones. You're going to bind up your hormones and make them unavailable to work in your body, and that happens with age, pregnancy, oral estrogen therapy. We talked, remember, about sometimes women need to go through their skin to get estrogen. Anti-electric drugs mean if you have a secret disorder, that can change your sex hormone globulin levels. Anorexia, cirrhosis, hypothyroidism, treatment with glucocorticoids. So that's steroids. And there's a lot of steroid administration now. You know, people with joint pain or back pain or allergies. It's not uncommon for people to get, you know, an injection for one of those things and or be on a dose pack or a tapering dose of steroids. And then people who have issues with their pituitary or the Addison's disease, that is the adrenals, which I talked about earlier, the stress organ. I also always evaluate people for thyroid across the board. It's one of the most important hormones in the body. It interacts with all of your reproductive hormones. So we're doing very extensive thyroid testing in practice, and oftentimes picking up people that maybe do traditional testing may not show that they're low thyroid, but indeed they do need thyroid support. Low iron, vitamin D deficiency, or elevated prolactin. Prolactin, you know, some people have these little micro tumors in their brain that can actually produce prolactin, and that can create issues with low testosterone. So we're looking for all of these different things. Ultimately, what I try to achieve with patients is what I call the Goldilocks principle. You know, you don't want too much, you don't want too little, you want it to be just right. And that's really the case. And I think, you know, what happened with women is we just gave them a lot of hormone. It was synthetic. We weren't measuring levels. We saw tons of side effects and problems. We got very concerned about hormones and what they do. You know, so we swung the other way. Some women are very afraid of hormones and concerned about the negative parts that they can play. And indeed, again, if not done correctly, those are real risks. But you know, that's the too much and the too little, and I think there's really the sweet spot of trying to reproduce nature and put these hormones back in the body like they were originally there in balance. That really supports health and well-being. So, you know, again, hot flashes, night sweats, vaginal dryness have been addressed, but this moving piece that's so important for testosterone replacement, the energy and just a general sense of well-being in postmenopausal women are really incredibly important to me, because you may be at the half point of your life, you know, and I always ask women, how do you want to live? You know, what do you want this to actually look like? Testosterone is really, in my mind, the forgotten hormone. I mean, I see women all the time that come in, they've been postmenopausal for a long period of time, and they may have received estrogen or progesterone, but they've never been on testosterone, and they're not even really thinking it's important, because they're thinking about it as a male hormone. And certainly there's a lot of clinical studies now, larger studies that are looking at testosterone and effects in men. You know, men have their own picture with declines of testosterone as they age, that we now call andropause, but I think it's really important for us to continue to study the effects of testosterone on women, so that we can really understand all the health benefits and really get it right for women. And then these are those references. You know, sometimes people like to have these things. If you're interested ever, you know, you can dial these things in and read these studies. You know, I know that women tell me, well, even if I read them, I don't understand them. But just know that it's important to me to kind of stay in this literature and stay in this information. And since the Women's Health Initiative study, there's really been the release of a ton of new information on hormones and their effects today. So I think it's important to get that word out about, you know, where are we and what's the latest science there. So that is everything that I have for you, and I'm happy to answer questions.
When I see the doctor, what kind of test is the doctor intending to do up the hormones? What are the main things?
So he's going to actually measure these actual hormone levels in your body. You know, so I'm measuring estrogen, I'm measuring progesterone. I do it differently in a cycling woman versus a non-cycling woman, and some women can have menopausal symptoms but still have cycles, for a period of time. You're going to have your testosterone level measured, and sometimes I'll get back a total testosterone, which means it's the free component that's not on that sex hormone, vitamin, globulin, and protein chip that I mentioned, and the bound form that is on it. And we've got to know what's free and available and what's bound by knowing that sex hormone. It's measured through blood. So they're going to take a blood test, and we're going to order the right things on you to actually evaluate where your hormones are. We're going to look at your DHEA levels. We're going to look at your thyroid. We're going to look at your iron. We're going to look at your vitamin D levels. We're going to measure these things and know where that balance is.
Can someone they feel fine going out in life?
That's a great question. So every woman's journey into perimenopause and menopause will be different. Some women will be profoundly affected in terms of how they feel, how they think, where they are emotionally. Other women will have none of those feelings, but all of a sudden their cholesterol will rise. Their bone density will change. Some women don't get any of that, and it's mainly cognitive issues, where all of a sudden they think, I can't think, I can't really, form a sentence anymore. So every woman's journey is a little different. The reason that I really wanted to put up here, what does testosterone do in the female body, is, let's just say that, you don't have a partner or whatever, and the sexual benefit things in terms of testosterone are not important to you. I still think it's important for your brain and your heart and your bones. So I think it's important to look at the health benefits of some of these things, as well as those more kind of subjective kind of quality of life, happiness, energy type pieces too. And I think it's hard for women to maintain their weight postmenopausally without testosterone. Just because again that biochemistry has shifted and changed.
So at what age does menopause come back? Is this what you're just assaying, or is every woman's different, or
every woman is different? Again, this is kind of bell-shaped curve that they talk about. I think it runs from kind of the early 40s to the early 50s is kind of the average, and then if you're before that or after that, you're kind of outside of that bell-shaped curve. But the important thing is to be in touch with your body and how you're feeling, and really begin to ask the questions. And again, listen to those other lectures. We've got all these symptoms of different hormones and what happens if you're too high or you're too low. So if you really begin to kind of tune into those things with your body and listen to them, you're going to sense when things are hormonally off. And that's why I said too, the thought that, just women postmenopausally are depressed. Well, my question always becomes, if you put back into the body what it needs and it begins to function again, were you really depressed to start with? It's kind of like diabetes. I mean, people that come in and they have a diagnosis of diabetes, and we change their food and change the things they're doing, and their blood sugar normalizes. Do they really have diabetes? I mean, I have no doubt that they have blood sugar dysregulation, but if you actually correctly manage that, again, those symptoms and issues go away. Yes?
DHEA, let's relate testosterone production to DHEA suppositories.
It can. So in the premenopausal woman, the DHEA is made again, remember, through our adrenals, the stress organs that are sitting on top of our kidneys. And that is a lesser contributor to testosterone premenopausally. Postmenopausally, it becomes a significant contributor to the amount of testosterone a woman counts. And every woman's body is going to be different again in terms of how she converts DHEA into testosterone. So we're measuring DHEA levels, and then we're seeing in a woman, how much does she convert into testosterone. Again, if that DHEA converts into your testosterone and gives you adequate levels, then that's great. But you just want to know if that's happening, and you want to know where each of these hormones are.
Take that instead of testosterone? I mean, possibly.
It depends. Yep. So again, we would measure both DHEA and testosterone pre-administration. So before taking DHEA, we would give you the DHEA, and then we would see how did that affect your DHEA level and how did that affect your testosterone level. So we'll have all those pieces of information. It's really again about, we don't want to guess on these things, we want to get it right and actually objectively look at these different levels and know exactly what your body is doing and where you are, because different people do different things.
After your first testing, you kind of figured out what each person needs. How quickly then do you retest?
So usually the first prescription that I give to a woman is going to be for a month, because if it's wrong in terms of how she feels, or she calls me with any issues of excess or still deficient symptoms and we have to go up, I don't want her to have a bunch of the wrong dose. So usually then we'll go, if everything's fine, we'll go into the second prescription, which is the second month, and we'll usually check those hormones out in a month. So typically about 6 weeks. And the thought there is you don't want to leave somebody in hormonal imbalance for any period of time. You want to measure that level, get it replaced, get into that target zone, and then leave them alone, and then I check annually. So if there's something that's not right, then we're going to adjust that level, right? And we're going to go recheck that. If something's perfect, we're going to leave it alone. So it's pretty logical and straightforward. It's interesting, that's why we do all other hormone replacement therapy in the body, thyroid and everything else. We just didn't do it with women and and it's one of the reasons I think that we had issues with things like synthetics, not measured levels, not personalizing it to the individual, kind of just doing a one size fits all. Every woman gets hormone. If you have uterus, you get hormone. You get more metabolic symptoms, you get more hormone. That's kind of what we were doing before when we were thinking about this in that disease-based period.
I don't have to know what the biochemical hormones are. What are the names of the
So they're made from either typically soy or yams. When you go into those plants and you're able to extract a molecule that's very close, but still not identical to the hormones in your body. So that compound that's extracted from soy or yams that goes to a chemical lab where they're able to chemically attach those last little pieces that make it look identical. So literally, structurally, it's a snowflake that looks like this. You want another snowflake that looks just like that, and they may have a couple little arms missing, but the lab actually puts those on so it's identical. Then you can put that into the body and know it's exactly going to fit where it needs to. It's like a lock and a key. It's an exact thing that fits that lock. So it is done. I was asked a great question a couple seminars ago. So is all women's estrogen the same? And the answer is yes. So we all make estradiol, we all make estrone, we all make estriol. So it's not like your estrogen is different than your estrogen is different than your estrogen. But it's important that the estrogen, that's human estrogen, that we all make, that's what we're trying to get to in terms of this chemical compounding, that we then, right form, right level, right balance, that we work with it that way.
Have you had an experience with people that have a problem with soy? They have a disease?
So there we go again. So typically, when we ask them about that. And usually, even if they do have issues with soy, they're not going to have issues with the soy-based hormones, but we always do have the Yes.
I'm 69 and I'm still using HRT with the cream and with testosterone in it. But my doctor doesn't believe in testing the levels.
Yes.
But I'm using it because I feel good.
Yeah.
But if I continue using it.
So two things. When women ask me, how long do I do hormone replacement therapy? Because remember when we said, oh, the Women's Health Initiative study, there's all these risks associated with menopause. A couple years down the line, this thought process of, well, if they're bad, but they're controlling menopausal symptoms, then we're going to give them to women for a short period of time to try to get them off of it as quickly as possible, because we don't want them to have those risks, even though they're feeling better. So for me, the bioidentical hormones is a totally different way of thinking. So remember going through all those health benefits? My answer is always, as long as you should stay on them for as long as you want those health benefits. When we did our estrogen lecture and our progesterone lecture, all sorts of health benefits. So you stay on these hormones as long as you want. Biochemically, those keys to be fitting in those locks to signal that kind of function with the organ system. I do believe that hormones are part of youthfulness and part of health. We have them when we're young. They're in balance, our body's making them. It's doing this tremendously amazing job of, orchestrating all this production. And we're young and healthy and vital. And I think, we live in a different world where women, again, live half of their lives, typically after menopause. Used to, get eaten by a lion, died in childbirth, died of infections. We didn't live as long as we're living. And so I think it's each woman's decision about how she wants to navigate through that period of her life where she doesn't have the hormones that she had when she was younger. And let me say too, I'm not one of those physicians that like every woman has to do this, you must do that. I don't think that that's the right answer either. I think the answer is to support women in their journey in terms of health and educate them and give them information. So that's the answer to how long would you stay on that. So, that's why I always emphasize too, because I see a lot of women who have been on hormones, who never had levels tested, or have been on hormones and they're having issues and their doctor really doesn't know necessarily maybe how to use the levels to get them into balance. I think levels are incredibly important. I'm kind of like the blood, Nazi in my practice, because I really, I think hormonal imbalance creates risk, just like any sort of imbalance in the body. I believe that, most disease is about some sort of imbalance, right? And so what you're always trying to do is recreate that balance. And you can't create it without some objective piece of data and information. Physicians used to say, I don't want to measure levels because they fluctuate and, they change, and all of that is true. But when you know how they fluctuate, and you know that there's a range that you need to be within, then this is the range for estrogen, and you're up here, you're too high. And you've got risk of being too high. And if you're down here, then conversely, you may not be getting all the benefits of estrogen that you're taking it for in the first place. So that's my thinking. I really want to be scientific and objective. And what that's done in my practice, and this is why I'm a believer, I've treated thousands of women, and those women feel great, and they don't have disease risk. And when I'm talking about disease risk, I'm talking about all this stuff that you hear about, like breast cancer and stroke and all these bad things, that you can get concerned about hormones. Our risk profile is beautiful. And so, I think we all do it a little differently, but that's my own personal bias.
We see men and women on hormone replacement therapy in their 80s and 90s. And I feel like I can tell a difference. Seeing, I have a 90, I think he's 91, and he is so sharp. He's using hormone replacement therapy, and he just seems like more muscle mass and everything than you think of like a normal 90-year-old man.
And I'll say too, so my practice is integrative medicine, and so we do a tremendous amount of hormonal work, we do a tremendous amount of thyroid work. We're going to do a lecture specifically focused on thyroid because it's so important to know about. But you know, those people who are living into their 90s, you know, healthy, cognitively, you know, together and, you know, good energy and are traveling and doing all the things that we think about, you know, what are the keys? And I think it's, you know, it's eating well, it's sleeping well, it's stress reduction, it's always moving your body. The moving your body part is a critical piece of that whole thing, and I think hormones are too. And that's what we're trying to always put together in my practice, those pieces. But you know, can you just take hormone replacement therapy, have a terrible diet, and sit around and not move your body and do those things? No. You know, it's really not having them all. But I do believe that hormones are a critical piece of that. You really do want to have that. And you can't get the same thing out of it that you can get with it.
I said, I've known several and for a period of years I've had this hot flashes. So then the hot flashes stop.
Yep.
So if your hormones are imbalanced, what makes that stop?
So in early menopause, there's still a tremendous amount of kind of fluctuation that's going on in the body. And there's almost these surges of what the brain tells the ovaries to do is the ovaries are not listening, and sometimes it's yelling, hey, you know, get to work down there, and sometimes it's quiet. So it's all these shifts and surges that happen in the earlier menopausal years that create a lot of those symptoms that then can simmer down.
So that's another reason for blood testing regularly to see.
Yes. But, you know, again, when you look at, well, you know, this woman's not having hot flashes or night sweats. Most women do still have vaginal dryness, you know, a lot of them have sleep issues. But to me, again, well, you know, how is the female brain going to function without hormones? What about her bone density? What about her cardiovascular health? You know, what about achieving an ideal weight? That's why I really focus on what are the effects of these hormones in the body, other than some of the common things that we think about in menopause in terms of, you know, why did this woman get them? Get these hormones in the first place. So I think for me it's a little different process because I really have to get back hormones in terms of health.
So after you prescribe the first dose of hormones, do us a little test 3 days later, or only does it feel right?
So about 6 weeks. So we'll give that first month, and then if the woman's doing well, you know, we'll refill that second month, and we'll check during that second month the estrogen, progesterone, testosterone levels, whatever she's been put on in terms of a prescriptive thing that will change that level. Let's just say she has a normal estrogen level, and we're not giving estrogen. You know, she just has low progesterone and normal testosterone. Then we're only giving progesterone, and we're only measuring that level. You know, so it's very logical where you're measuring things, you're bringing anything that's deficient back into that target optimal zone. Every so often, you know, we have high estrogen, and we have to deal with that in terms of how the body metabolizes that and bring that back into that zone. But that's the goal, is that everything is in that optimal zone, and therefore everything is balanced in the body. Really, so hormones are like messengers that tell the other nervous systems what to do and when to do it, orchestrate this process. So when they're all in balance, that process is happening perfectly.
So 6 weeks later, we'll get the test for whatever's been added.
Exactly. Yep. And then if it's perfect, we leave it alone for a year. If it's not, we adjust the dose of what that person's been given and measure that level again. If, you know, let's just say we're giving testosterone and, you know, the woman calls me in 2 weeks and she says, oh my gosh, my face is, you know, breaking out and so on and so forth, and, you know, we think her level's too high. Then sometimes, just based on what she's saying, we'll lower the level and then, you know, give her a longer period of time for that to kind of equilibrate with her body and check it a little bit later. But if everything's perfect and the person's feeling good, we will typically go in at 6 weeks.